Good afternoon. Yong here. Can anyone hear me clearly? Okay.
Yes, we can hear you.
Okay. Good afternoon, Dr. Suha, Dr. Josiah, and also specialists and also my colleagues. Today, me and Ashwin will present on the topic of pulmonary embolism. So I think this is a frequent issue that we encounter in medical practice. So we will start off with, as usual, with a case presentation. So for the case that I'm going to present today is a 65-year-old gentleman with underlying multiple comorbidities, diabetes, hypertension, hypercholesterolemia, and also history of rectal sigmoid adenocarcinoma, done operation and in remission. So, and also this patient coincidentally also have a recent admission 2 months ago for left cerebellar bleed secondary to hypertensive emergency and has been ADL semi-independent after the cerebellar bleed, ambulating with a walking stick. So this patient actually presented with a sudden onset SOB at home, followed by a loss of consciousness. He was walking down the stairs at home and suddenly developed SOB and subsequently sat down. And the family said subsequently he lost consciousness, but before that did not have any chest pain. And also he had an underlying complaint of right lower limb swelling for the past 2 months, and also some altered bowel habit for the past 1 week. So it took about 15 minutes for the family to bring the patient to the hospital, where the patient was unconscious throughout. And on arrival in ETD, the patient actually has no palpable pulse, and cardiac monitor showed asystole, and the CPR was subsequently commenced and for 4 cycles, and the patient was crash intubated. After 4 cycles of CPR, there was RSE, and patient post CPR patient required maximum dose of IVI NORAD for BP support. And post CPR, pupils were sluggish, BP was borderline on maximum dose NORAD, and lungs were clear, and the right lower limb was swollen until the below knee level, only unilateral swelling. So in basic echo was done in ETD, showed dilated right atrium and right ventricle. The left ventricle contractility was normal, but compressed, but no pericardial effusion. So there was also D-shaped LV, no and also distended IVC. I'll explain more about the echo later. And ECG showed no dynamic changes. Patient is sinus rhythm, but there's a RBBB pattern with small complexes, but no ST elevation. For the blood investigations, generally the significant one is that patient have severe AKI, probably because post CPR, urea 37.6, creatinine thousands, high lactate, pH of lactate of 7.2. and bit of compensated metabolic acidosis and a high troponin I at 129, and X-ray is quite clear. So in view of the presentation, highly suspicious of PE with dilated right heart, proceeded with urgent CTPA, which showed acute bilateral pulmonary embolism, extending to the secondary and tertiary pulmonary arteries, but sparing the pulmonary trunk, basically a bilateral massive PE. So according to the ESC 2019 guideline, so it fulfills the criteria for a high-risk PE, where the patient has a cardiac arrest on presentation. So subsequently, the patient was referred to cardiothoracic team for role of surgical embolectomy, but the input was there's no surgical intervention. Was referred to cardiology team for the role of thrombolysis. Input from cardiology team was for thrombolysis with high risk consent if the family agree, because there's a recent intracranial bleed within 2 months. But patient also presented with a very high risk PE with cardiac arrest. And family conference was done, and the indication of the thrombolysis and also the very high risk of bleeding was explained to the family, but the family was undecided and was given time to discuss with the other family members. So after discussion, the family actually agreed for thrombolysis with high risk consent, and IV alteplase was given at 48 hours post cardiac arrest, followed by IVI heparin after completing the thrombolysis. And coagulation profile was done 4 hourly with the IVI heparin titrated accordingly. Patient hemodynamic improved subsequently, able to wean off the IVI NORAD, cut down the IVI NORAD, and also an ultrasound Doppler of the right lower limb was done, confirming a sharp DVT in the right lower limb. And unfortunately, after 36 hours on IVI heparin, patient subsequently developed frank hematuria, and the IVI heparin had to be withheld, and bladder irrigation was started. But after the after the hematuria resolved, circumflexane was started at the treatment dose. Unfortunately, patient had a poor GCS recovery, and then the CT brain done was quite normal. But the tracheostomy was subsequently done because of the poor GCS recovery. But the patient had an EEG done, which showed diffuse severe cortical dysfunction. And after referring to neuromedical, it was concluded that the patient have HIE, secondary to prolonged hypoxia during the initial CPR. So DNR was eventually issued to the family in view of poor prognosis and low chance of recovery. Patients were subsequently transferred to general ward for family to learn nursing care, but subsequently passed away on the day 20 of admission because BP progressively become hypotensive and subsequently asystole. And in view of the DNR status and patient already having HIE, no CPR was done. So this brings us to the theory part of the presentation. So basically our presentation today will be mostly based on the 2019 European Society of Cardiology guideline on pulmonary embolism. So basically a little bit on the pathophysiology. So basically PE is an obstruction in the pulmonary artery causing right ventricular failure. And in view of the reduced LV left ventricular preload from the right ventricular failure, patient has shock. And then due to the ventilation perfusion mismatch, patient has respiratory failure. And most mortality from PE actually comes from the right ventricular failure. And as for the clinical presentation, it's important to know whether patient has any risk factor for PE, which is the usual risk factor that we look for, like a previous history of VTE, any reason lower limb fractures, post hip replacement or knee replacement, any malignancy, whether the patient has prolonged immobilization, whether the patient is pregnant, or whether the patient is obese, or any reason prolonged air or car travel, or whether any OCP use. And the usual symptoms for PE are dyspnea, chest pain, either thoracic or angina in nature, hemoptysis, syncope, or even in the more severe cases, even cardiovascular collapse, like in the case we just presented. So the presentation of PE is usually very non-specific, no particular specific symptom. So a high degree of suspicion is needed to actually diagnose and treat PE. So hypoxemia is frequent in PE, but in very small PE or very small segment PE, SpO2 can be normal. But however, hypocapnia is usually the PCO2 is low or normal, as the patient will be hyperventilating. Just some ECG changes in PE. So this one shows the typical S1Q3T3 that we are familiar with. Deep S wave in lead 1, deep Q wave and reinverted T wave in lead 3, which is specific but not common in PE. And also T inversions in the right ventricular leads V1 to V4, or RBBB pattern of ECG. But the most common one is still just sinus tachycardia, which is non-specific. So, so it's important to know what is considered a high-risk PE, because these are the patients that may require thrombolysis. So according to the ESC 2019 guideline, basically high-risk PE means any patient that comes in with cardiac arrest or has hypotension, which means the patient is in shock. Whether the patient requires inotrope or the BP is the systolic BP is less than 90, despite having adequate volume lah. That means even after fluid resusc, without any other complicating factor like arrhythmia, sepsis, or hypovolemia. And so the approach to diagnosis for PE differs between patients with hemodynamic instability and also those without hemodynamic instability. So for patient with hemodynamic instability, in which the patient come in with shock, the further management and diagnosis will depends on the bedside echocardiography, whether it shows right ventricular dysfunction or not. If the patient is in shock and the bedside echo actually does not show any right ventricular dysfunction, so the PE as the cause of hemodynamic instability is unlikely. However, if right ventricular dysfunction is present, the patient should proceed with an urgent CTPA. So just just to show some images on what are the typical findings in right ventricular dysfunction. So you can see on the left side is a normal heart. The left atrium, aorta, and also right ventricle should be about the same size, same diameter. But if the right ventricle is dilated on the right side, we can see the RV, the right ventricle diameter is much more than the left atrium or the aorta. This is in the parasternal long axis view. So in the parasternal short axis view, on the left side, we can see a normal heart. During systole, because the LV pressure is high, always in normal heart, the LV pressure is higher. So the septum actually is towards the RV. But in a patient with massive PE, the RV pressure is actually very high. That's why in systole, the RV pressure pushes the septum towards the left ventricle. So we can see the D-shaped LV in systole if there's right ventricular dysfunction. And also dilated RV. In the LV and RV is the left ventricle is supposed to be larger than the right ventricle in apical view. But if there's PE, the right ventricle may appear larger and maybe larger than the LV because it's dilated, and also there's a McConnell sign. What we mean by McConnell sign is there is akinesia of the right ventricular free wall, but there's preserved contraction of the apical region of the right ventricle, where we can see the apical region of RV is still contracting, but the free wall is akinetic. And also the IVC will be distended because of the high right atrium and right ventricular pressure. Okay, so this so basically just now is the approach to diagnosis in a hemodynamically unstable patient. But in a hemodynamically stable patient, the patient present did not come in shock. So we can apply the Wells score that we are familiar with. And if the patient has a low or intermediate probability based on Wells score, then we can proceed with a D-dimer test. So to try to attempt to exclude PE. But if the patient have a high clinical probability of PE on well score, the patient should proceed straight with a CTPA. So this is the well score, basically a scoring based on the patient's whether to score the patient, whether is patient at risk of PE or not. Component include whether any previous PE, whether the patient is taking cardiac or not, any surgery, hemoptysis, cancer, any clinical signs of TVT, or any alternative diagnosis that is less likely than PE. And it can be scored into low, intermediate, or high probability. So if there is intermediate or low probability, a D-dimer should be sent. So if the D-dimer is low, then PE can be safely excluded. But if the PE is the D-dimer is high, then we will need to proceed with a CTPA to see whether there's PE or not. So in general, D-dimer testing has a high negative predictive value. That means a negative result is more useful than a positive result because there's a lot of false positive among patients with cancer or any infection. So just a bit on the imaging modalities for pulmonary embolism. So the usual ones that we do is CTPA, computed tomographic pulmonary angiography, which can visualize the pulmonary arteries up down to the subsegmental level, and it's very sensitive and specific. It's easily available, and also you can also provide other diagnoses, like you can see pneumonia or pleural effusion on CT scan also. But the weakness is that it has a high radiation, which makes it more difficult to use in a pregnant lady. And also there's a risk of contrast-induced nephropathy and also contrast allergy. Other modality include VQ scan, but this is very much less commonly used. But yes, it involves radioisotope, but then the radiation dose is still lower, much lower than CTPA. There's almost no contraindication. It's highly specific and has a low radiation dose, but it's not readily available, and it has a very low sensitivity, almost inconclusive in 50%, and it doesn't help in giving other cause for the hypoxia. Okay, I will pass over to Ashwin for the next slides.
Okay, thank you, Yong. Good evening to Dr. Suha, Dr. Josiah, everyone, my colleagues as well. So I'll be presenting mainly on the assessment of severity and also the management of acute PE. So as I go along, if you have any questions, please don't hesitate to stop me at any point of time. But before I begin, I'd like to just mention what I will not be presenting on. So I won't be presenting on PE in pregnancy, PE in patients with malignancy, or the long-term sequela of patients with PE. So our emphasis today is mainly on the severe acute PE. So I think once you diagnose PE, the next step is to assess how severe the PE is. So we do so based on 4 parameters. So one, we look at the hemodynamic instability, and I think as Yong alluded to earlier, patients who are unstable are those who either undergo CPR or those who require vasopressors, who are hypotensive, which is not explained by hypovolemia, arrhythmia, or sepsis. The next, we look at a set of clinical parameters. So for that, we have a objective validated score, which is the PESI score. The PESI score is the PE Severity Index score, and there's also a simplified PESI score as well. The third and fourth thing we look at is the presence of RV dysfunction and also the presence of elevated cardiac troponin. So based on these 4 parameters, we'll be classifying the patients into high risk, intermediate risk, and low risk, as I'll be showing you in the next slides. So this is the PESI score. So you can see on the left, so there's the original version, which is the long PESI, and then the simplified version, which is the S-PESI score. So they take into consideration many different variables. They look at the demography, they look at the vital signs, the patient comorbids, and each points have its own weightage. And based on your points, if you look on the right, you classify the patients into class 1 to class 5 if you're using the PASI score, or 0 to 1, 0 or more than 1 point for the simplified PASI score. Now, essentially what this score does is it tells you the mortality risk at 1 month, at 30 days. So in the very simplest sense, a patient with class 1 PASI has a mortality of less than 2%, 0 to 1.6%. And patients with class 5 of a PASI score has a very high mortality exceeding 10%. Okay, so this is what I mentioned about how we divide the patients into the various risks. So we look into the 4 parameters, which is hemodynamic instability, the PASI score, the presence of RV dysfunction, and also elevated cardiac troponins. So based on that, we will divide the patients into high risk, intermediate risk, and low risk. But the intermediate risk patients are further subclassified into intermediate high risk and intermediate low risk. So in a very simplest sense, any patient with instability is automatically classified as high risk. Okay, and any patient with absence of any 4 of these parameters, that means they are not unstable, they do not have a PASI score of at least 3, there's no RV dysfunction, TROP is negative. If everything is negative, they are low risk. Now the tricky part is distinguishing between intermediate high and intermediate low risk. Essentially, all intermediate risk have a PASI score of at least 3. Okay, but how you differentiate between the high risk and the low risk is you look for the RV dysfunction or cardiac troponins. If both are positive, then they are high risk, intermediate high risk, sorry. And if one is positive or non-positive, then they are intermediate low risk. And it's very important to classify them accordingly. All right, moving on. How do we manage PE? Some basic principles. If the patient's hypoxic, give oxygen. Try to avoid intubation wherever possible. If your patient is tachypnic, try to go for HFNC or NIV. The issue is when you intubate, there's a lot of positive and expiratory pressure that is going to reduce your preload. It's going to cause hypotension and your patient will code. So wherever possible, try to avoid intubation. But if it's inevitable, then use inducing agents which are hemodynamically neutral, like etomidate. Also consider low PEEP and low tidal volumes. The next thing is fluids. Most patients with PE, through PE, they don't require fluids. Always use your IVC to guide. I think as Yong has showed, many patients have obstructive shock and their IVC is just dilated and they are not really moving. In those patients, you probably do not need much fluids. But if you do see some variation in your IVC, you can give some judicious fluids, but perhaps they don't really require much. Vasopressors, some patients who are still persistently hypotensive, of course, you're going to start vasopressors. NORAD would be your first choice. If you require a second vasopressor, inotrope, then go for dobutamine. Defend your MAP, keep your MAP more than 65 for perfusion. All right, now talking about the definitive management. So basically, it's a double prong. You anticoagulate and you reperfuse. For anticoagulation, quite simple. Every single patient, despite of risk, high risk, intermediate, low risk, you would anticoagulate them unless they have an absolute contraindication. But for thrombolysis, it's a bit more tricky. High risk patients, good amount of evidence, yes, you thrombolyze. Low risk patients, yes, you do not thrombolyze them. Okay. For intermediate risk is where it gets a bit gray. Intermediate low risk, you do not thrombolyze. But for intermediate high risk, we still don't know. Okay, that's still where the evidence is most gray. The current consensus is you do not routinely thrombolyze them. So what you do is you wait and watch, especially in the first 3 days. That's when they are most likely to deteriorate. If they do deteriorate, then you do something called as a rescue thrombolysis. Means if you watch and wait, if they get hypotensive, if they are now unstable, then you thrombolyze them. But going further into the intermediate high risk group, is there a rationale for us to thrombolyze them? So basically, every patient with PE, RV dysfunction is a factor which is associated with a worse prognosis and higher mortality. And thrombolysis is shown to reduce the RV dysfunction. So theoretically, it should cause some beneficial impact on mortality. But who do you select to thrombolyze in this group? It's very, it requires a good clinical judgment. So ideally, it should be a consultant level input. You require good clinical gestalt. So likely the patients who are the sickest among the intermediate high risk group might benefit from a thrombolysis. Now, if you were ever to thrombolyze them, probably you would not give the full high dose thrombolysis, probably you give a half dose or low dose thrombolysis, or you might consider wherever the facilities are available, you can consider catheter directed thrombolysis. Now, is there evidence for thrombolysis in the intermediate high risk group? Yes, there are a few trials, none of them high quality, but it does show to improve the RV indices. It does show to improve the RV dysfunction, but whether or not there's effect on mortality, still very unclear. So use good clinical judgment in these patients. Okay, this is a flow chart, a very nice flow chart taken from the ESC. So every patient with acute PE, you anticoagulate them. Look for the presence of hemodynamic instability. If that's there, then you thrombolyze. The next step, if they're not unstable, is to differentiate between high risk, low risk, and intermediate risk. So you look at the presence of the PESI score, RV dysfunction, troponin, and you divide them accordingly. So patients with an intermediate high risk, you watch and wait. If they deteriorate, then you rescue thrombolyze them. Patients with intermediate low risk, you definitely hospitalize them, but you won't thrombolyze. Now, it's interesting to see that the low risk patient, some of them may require hospitalization, and there's a very small subset of them who you can discharge early and give an outpatient treatment. So patients who there's a criteria called as a Hestia criteria, which I'll be showing you in the subsequent slides. So if they are negative on the Hestia criteria and they are low risk, you can essentially discharge them. So that's interesting to know. Not all PE requires inpatient management. Yeah, this is a table showing the thrombolytic regimes. So the most commonly used is your RTPA or your alteplase, as you can see on the left of the table. So your usual dose is 100 mg over 2 hours. But as you can see, there's a second dosing as well, the accelerated regime, which is your alternate dose. You can give 0.6 mg per kg over 15 minutes. So that dosing is actually off-label dosing that's basically used for patients who ongoing CPR and you're highly suspicious of a PE, then that's the off-label use of RTPA. But regularly, the regular dose is 100 mg over 2 hours lah. Other thrombolytic agents you can use is streptokinase and urokinase, although less used commonly as compared to alteplase. And always before thrombolysis, assess your patients for contraindication to thrombolysis. So you have your absolute contraindications and your relative, I think much of which we are quite familiar with. But just a note, not all absolute contraindications are always absolute. I think as Yong's case earlier, patient with a recent cerebellar stroke, cerebellar hemorrhage 2 months ago, yet they thrombolyze. So always use your clinical judgment in every case. Where the benefit clearly outweighs the risk, probably you can consider thrombolysis in those patients. Okay, so there are other methods of reperfusion as well. So there's the percutaneous catheter directed treatment. So essentially, much like your angio, you put a catheter into the femoral vein and you approach the pulmonary artery. All right, and then by that catheter, you can do a lot of fancy things. So you can use ultrasound to fragment the thrombus, you can aspirate, you can inject saline. So there are multiple ways. You can even give a very low dose thrombolytic agent. So that's more advanced. Not many centers have it. Any evidence so far, all the evidence, mostly they are funded by pharmaceutical companies, a lot of publication bias, but most of the research shows lesser bleeding. So you can consider this treatment in patients with high risk of bleeding. Yeah, you can consider this treatment lah. Surgical embolectomy, you need to refer to CTS. What are the indications? Any patient with an absolute contraindication to thrombolysis and who are hemodynamically unstable, yes, those are the best patients. Any patients for which you tried thrombolysis and failed, yes. And another indication which we don't commonly think of is any proximal emboli, especially if it's abutting the foramen ovale. If you thrombolyze them, you risk embolizing a thrombus into the systemic circulation. You can cause a stroke. So those kind of patients, probably it's best to refer the CTS team. Okay, now on anticoagulation. Now, there are certain patients, especially where your suspicion is high, you would start empiric coagulation, anticoagulation. So you need to always outweigh the benefits versus the risk. So who would you start empiric anticoagulation for? Any patient with a low bleeding risk, if your suspicion is moderate to high, that is, if you have a well score of at least 2, then yes, you would anticoagulate them empirically. Any patients with a high bleeding risk, probably you'd want to wait for the diagnosis before anticoagulating. Anyone with a low bleeding, moderate bleeding risk, you do it on a case-by-case basis using your clinical judgment. Now, how do you differentiate the high, moderate, and low risk of bleeding? There's this table which I've taken from UpToDate. So multiple factors taking into play, from your age to your comorbids, your medication use, and essentially you divide the patients into low, moderate, and high risk. So if they have 0 risk factors, they are low risk. If they have 1 risk factor, they are moderate risk. If they have if they have 2 risk factors or more, then they are considered high risk. So some risk factors are quite common: anemia, diabetes, your age. Most of our patients we see on day-to-day would fall in the moderate to high risk category of bleeding. Okay, patients with confirmed PE, anyone with a high risk PE, you start unfractionated heparin, IVI. That is better because it's a short half-life. You can stop anytime. If there's a bleeding, you can reverse. Patients with intermediate to low risk of PE, you can start anticoagulation with Clexane or Fonda. Okay, but also recent evidence shows you can start NOACs right from the offset, so you don't need to give parenteral. You can start directly with NOACs over BKA lah. It's preferred over warfarin, but your NOAC, only 2 which is shown, which is studied in the initial phase of PE, which is rivaroxaban and apixaban. But there's a high dose which you give. That's not your usual dose. So for rivaroxaban, you give 15 mg BD for 3 weeks. So that's a higher than usual dose. And then you reduce to 20 mg OD. For apixaban, 10 mg BD for 1 week, and then 5 mg BD. So the dosing is different than your usual. So it's good to be mindful of the increased dose of these 2 NOACs. Yeah. So PE, can I discharge? Yes, as I mentioned earlier, there are some subsets of patients which you can discharge. Essentially, any patient with a low risk PE and a negative Hestia criteria, you can consider for discharge and consider for outpatient therapy. So below, the table below is actually the Hestia criteria. So it takes into consideration many things, from your vitals to your comorbids to even the social aspect of the patient. So essentially, if you tick no to everything, then yes, you are fit for discharge. If you even tick 1 yes, then probably it's better to admit the patient and observe. Okay, looking at the chronic treatment, this is like after your acute phase, you need to decide how long you want to anticoagulate the patient for. And so you need to determine the risk of recurrence of the patient, and then from there you can decide the duration of therapy. So I think previously what we are all familiar with is the term provoked PE, unprovoked PE. So your provoked PE would anticoagulate for 3 months, and your unprovoked for at least 6 months to a year, sometimes lifelong. So the latest ESC guidelines has asked to refrain from the use of provoked or unprovoked PE. So now we classify patients into the risk of recurrence. So the risk of recurrence is classified into low risk, intermediate risk, high risk. Looks very confusing, but to put it in a very simple way, patients with a low risk of recurrence is anyone who gets a PE from a major transient reversible factor, Usually this risk factor is very obvious. For example, a patient who has a surgery under GA for lasting more than 30 minutes, or they are in hospital confined to bed for more than 3 days, or they have a limb with a fracture, the risk factor is usually fairly obvious. Okay, patients with an intermediate risk of recurrence, usually the risk factor is a very trivial risk factor, something not very obvious. Okay, so these are patients that you suspect they are getting a PE from a trivial risk factor, hence they are of course at high risk to get a recurrent PE. So for example, a patient who gets a PE from a minor surgery, minor surgery is defined as GA for less than 30 minutes, or patients who are pregnant and get PE, or using OC pills and get PE, or patients who have undergone a long haul flight and get a PE. So all those are very minor transient factors, and those patients are put at an intermediate risk of a recurrent PE. Or patients with a persistent risk factor, the risk factor is there lifelong. For example, a inflammatory bowel disease or autoimmune disease, those are also classified as an intermediate risk factor. Patients with no risk are also considered as intermediate risk. Now, your high risk group, there are three major causes. One is your cancer, which is not treated. A recurrent VTE, any recurrent VTE is a high risk VTE. Any patients with antiphospholipid antibody syndrome is a high risk of recurrent VTE. Now, how long do you anticoagulate them? Any low risk patient, at least 3 months. Okay, then you reassess them. Patients with high risk, they need indefinite anticoagulation, so you don't put a stop date for them. Patients with an intermediate risk of recurrence, you would give them an extended period of anticoagulation, so for 6 months to 1 year, and where necessary, sometimes indefinite anticoagulation. Okay, a very short note on the long-term sequelae. So what are the most common complications is one is a risk of recurrence. So any patient with a VTE, they are always at risk for a second VTE. So always suspect that when a patient comes to you in the ED. The next sequelae, which is quite important, not talk much of, is a condition called as CTEPH, which is chronic thromboembolic pulmonary hypertension. So that affects up to 5% of patients. So you suspect that if a patient comes to you with persistent dyspnea or progressive dyspnea, despite being on anticoagulation, within 3 months to 2 years after the diagnosis. So this flowchart is taken from ESC. I'm not going into detail, but basically every patient with PE, you anticoagulate them, you follow them up at 3 months, and you assess them for dyspnea, and you also assess their functional status. So anyone with shortness of breath, anyone with a reduced functional capacity, you would want to get an echo looking specifically for signs of pulmonary hypertension. Now, if the patients with signs of pulmonary hypertension, those are at risk of CTEPH, for which your next step would be a VQ scan, and you refer to cardiology for further management. So the management aspect I'm not covering here, but that is something interesting to look at later. So that's it for my presentation. Thank you very much. Anyone has any questions so far?
Hi, Eng here. Hey, thanks for a nice presentation. My question is to Yong. Just want to ask, because there were a number of there's a number of reperfusion choices that we can give for dosage, especially for altar place. I want to clarify why for that particular case that you presented, right? The team in question gave the accelerated regime as opposed to the full 100 mg over 2 hours.
I'm at the time I'm not sure why exactly is the reason that was we chose the regime now. But then usually if for unstable patient, usually we give the 15 minutes regime rather than a 2-hour regime.
Yong, I think probably next time you may want to ask the primary team in question, because that particular case was the case that I managed. Okay, that's number one. The reason why we decided for that particular regime was because we were balancing the risk of bleeding in a patient that had a history of a bleed, which you have mentioned. Okay, so probably may next time you want to have a courtesy to just inform that you may be presenting the case and we will be able to describe the nuances of why we chose that particular dose. Okay, my next question is regarding when do we recommence unfractionated heparin after thrombolizing the patient? Because I think it was not mentioned when do we restart back the UFH, especially if the patient is still on inotropic support.
Okay, so of course, you would, during the thrombolysis, most of the evidence suggests to withhold your IBI heparin. Now, as to when to start after the IBI heparin, I'm not too sure, but I've read some accounts of you checking the coagulation profile, assessing your APTT, and when it's reasonable, when it's in a reasonable situation, then of course you would consider to start or you can monitor fibrinogen levels and then start your IBI after that. But I'm not too sure when exactly to start after the thrombolysis.
Okay, great. That's because you probably both of us are probably referring to that particular website regarding the timing. If that's the case, if I'm not mistaken, they mentioned traditionally to start at APTT less than 1.5 to 2, or they either do measure fibrinogen levels because thrombolysis will, after thrombolysis, you will have a reduced fibrinogen levels, and in certain cases where the fibrinogen is too low, you may trigger bleeding, which is something that we do not want to after we spent probably 4K on reperfusion part. Okay, that's great. Thank you very much for answering.
Thank you, Doctor. Any other questions?
Hi, can hear me?
Yes.
Justin here. I just want to ask because this is quite a common scenario that gets referred to us lah. So in surgery, they have a lot of cancer patients who get PE, and these patients, most of them need surgery due to their cancer lah. So the common referrals from them will be, once we start patient on OAC or warfarin or whatever for his pulmonary embolism, when can they proceed with a surgery? Because you can't wait until the months later down the road, because by then the cancer will spread, the patient will have died. So what would be the best timing? Because all I can find is that risk of surgery and risk of recurrence, risk of recurrence is always highest within the first 1 month of the treatment, and risk of recurrence is also highest within 1 month post the surgery. So whether there's any thoughts on that, which will be the best timing, how at week or what month of treatment before we breach and then they go for surgery?
Very tricky question.
Very interesting question. I think very practical and common challenge as well. I'm honestly not too sure what's the best way forward. Can we direct the question to Dr. Suha?
Yes. Hi, Ashwin.
Hi.
Thank you for the very informative presentation. Thank you to Yong as well. I think you guys did a fantastic job. So I congratulate you on the presentation. Okay, so coming back to the question by, who is the one who asked the question regarding the cancer patient?
Oh yeah, Justin here.
Justin, are you in the cancer unit or?
Oh no, because what happened is in Queen, the surgical department, they have a lot of cancer patients that
Right.
needs surgery. So it's quite common for them to refer us these kind of problems. Hepatobiliary cancers are mostly.
Mostly hepatobiliary cancers, and these patients, they need urgent surgery, yes?
Most, I mean, if we ask the surgeons, right, they always tell us as soon as possible.
Yeah, so I mean, I think that would be like a judgment call between the operating team and then the surgeons and the NS, because we want to also assess the patient, whether the patient is suitable for surgery as well, right? Because not all patients are the same. So I think that is going to be like a individualized decision, and it has to be like a disciplinary kind of thing, where you do a MDT and then everyone comes to a consensus and saying that, okay, you know what, this is the timing of surgery and this is how we are going to go, and when is the timing of surgery. But I think if the patient needs a high risk surgery, that okay, without this surgery, patient is going to die or something like that, then obviously you need high risk consent and you need to go in for your surgery. I think that is the most common sense. Nobody knows when is the period where patient is, safe for surgery and not safe for surgery, that sort of thing, because you have already thrombolized the patient and there is going to be a high risk of bleeding. So the timing of it will be dependent mostly, I feel, on the operating team. How confident are the surgeons going to go in a patient that has already been thrombolized? And I think that is the same thing that we face in patients who have been thrombolized, and we're going for a primary PCI, for example, for in our setting, where we need to do angiograms and all that. So that we will weigh the benefits as well as the risks involved, and then we will decide whether we should proceed or not. So do they ask you guys to sort of decide when patient needs to go for surgery?
Yeah, of course. So
Oh,
basically, their common question will be like this. Okay, this patient had a PE. We are discharging already. Well coagulated. INR is okay, or patient on OAC lah, whichever. And then they ask us. So now that patient is on warfarin, how long do we need to anticoagulate the fellow before we consider a surgery that is the safest for the patient?
right. So I think their main concern is the bleeding risk, right? Because patient is on warfarin. Is that
No, not that. That one is not their concern. Their concern is when is it safest to cut the patient after a PE event?
right? Okay, okay. So we are talking about a patient who came in with a severe PE. Am I right? And then he's been thrombolized and on warfarin, and after
No,
no,
not thrombolized. Most of their patients don't get thrombolized. Is to be
just
honest.
or anticoagulation, right?
Yeah, correct.
Yeah, so I think Ashwin presented a very good slide. Actually, if you can go back on how you risk stratify the patient. Some patients, they can be managed as outpatient, right? Yeah, you do have how you risk stratify the patient's early discharge and all that. So I think that, if the patient it doesn't come into the criteria of severe PE, intermediate high risk PE, and then if they are safe and they have been able to be discharged, then of course they can be planned for a surgery. And I think that is the best answer that we can give to the surgeons who are going to be deciding on the timing of the surgery. I think so. Is that a good enough answer, Doctor?
I mean, you can say that lah. It's just that the
Yeah.
surgery team.
So I think it's just a discussion, a multidisciplinary discussion thing to decide on the timing of surgery. That's it. There's nothing, no science to it, and there is no definite answer. It's not an easy answer to give. So that depends on the patient. Yeah.
Thank you, Dr. Kwok.
Okay, sure. Another thing I wanted Ashwin to show us is how to re-stratify patients, the PE patients. The before slides, Ashwin, the one with the if anyone here, so if anyone here sort of wants to know how to manage these kind of PE patients, I think Dr. Ng had a very considered a high risk patient high-risk PE patient, and I think he did his best to manage that patient. It was not an easy case to handle. So once it becomes high risk and there is hemodynamic instability, then I think the steps are quite clear. Number one, you refer to your surgeons for surgical embolectomy. You refer to cardiology, whether there's any role for catheter embolectomy, or you're going to go for thrombolysis. And most of the time, I can tell you guys that it's going to be thrombolysis because it's a very niche procedure. It's a catheter thrombolysis. We do have the penumbra system. We are trying to get the resources available to start the service, but it's not something that, like Ashwin mentioned, it's not something that's done in all the centers. And even in the biggest center, like Hospital Serdang, they're not doing it for all the patients. It is basically a case-by-case basis. So we can't standardize, okay, if it's high-risk PE, we are going to do catheter ablation, we are going to do surgical embolectomy. It doesn't work that way. And in our setting, I think thrombolysis is the first. Eventually, if the surgeons say no, cardiology, we are not doing the surgical, the transcatheter embolectomy. We're going to go for thrombolysis. Then you're going to go thrombolysis. You're going to decide whether patient is high risk bleeding or whether patient has a lower risk to bleeding. If it's higher risk to bleeding, then you need to inform the patient's family, and you inform patient, what, we have a high risk bleeding. You can't predict it, but you also have high risk PE. So you have to weigh the pros and cons, and then just decide. If you want to thrombolize, go for it. I'm just a small question to ask. Do you guys use Altiplace often in the medical team? Ashwin? Can you hear me?
Yes, hi.
Do you guys use Altiplace often in medical?
Yes, we do. Stroke teams use that frequently as well.
Okay, for PE, is it used in for high risk PE, or do you guys use streptokinase? Sorry.
Personally, I do not have much experience with unstable PE patients lah.
Right. Okay. Okay. So I understand. So I can tell you that in most, even in our districts in Sabah, when we have seen patients with high risk PE, patients, or even intermediate high risk, anyone with RV dysfunction, and we have decided for lytic, most of the time we are using streptokinase. We don't really use Altiplace that often. Because there is obviously a budget constraint and we don't really have the resources for it. So our setting, most of the time we're going to use streptokinase. And so the reason there is, if anyone is interested to go through the PE portfolio, there's a recent European acute cardiovascular care symposium sort of thing, where they talk about using Altiplace in the high risk patients with hemodynamic instability. They do use Altiplace, but there is a risk of bleeding. So when there is a risk of bleeding, that's why they're very cautious. It is not recommended in this intermediate high. Most of the time, like you mentioned, Ashwin, we do have these patients who coming in with massive PE, right? They do the CTPA, patient has SpO2 not so good, but their BP is considered like not too bad,
Yeah.
You have come in, right? Their BP is okay, not too bad, but they do have this RV dysfunction, a very classical, I think Yong showed us, D-shaped kind of RV dilated sort of scenario. Obviously, the troponin is going to be raised in all kinds of scenarios. And then you come to your intermediate high risk. So whenever you guys are facing this kind of problem, you use the PESI score. That means either a simplified PESI, I think you can use, like Ashwin has showed you, right? What are the criteria for the high PESI score? And this is considered like a high mortality. So when you already have this kind of patients with high mortality, and then you also see you already have some parameters, you're in the intermediate category. For us in cardiology, we give patient benefit of the doubt. That means we will counsel for lytic therapy. But in our setting, to be honest, what I'm using at this point is streptokinase. We don't use Altiplace. So we strap the patient. We say, you know what, go ahead, lytic therapy. But Ashwin, you're right. let's make it a discussion among consultants, among senior colleagues, that sort of thing, if you're not confident. But common sense being common, I think that if you are in the intermediate high risk, we will give patients benefit of the doubt. We will give lytic therapy if there is no contraindications, a patient has no high risk of bleeding. But like Dr. Ng's case, I think the patient who had a high risk of ICB, history of ICB before this, now that becomes tricky. You do have to let the patient's family know, let the patient know, you know what, this is high risk. So we have to inform the patient before giving this lytic therapy. Once you have given the lytic therapy, ultimately for PE, it's just anticoagulation and long-term, like you say, warfarin, and now they have NOAC, and most of the time, the patients make it, they don't come in so ill like Dr. Ng's patient. Most of the time, they're in that intermediate high risk, and I've seen most of the time they do well, they are discharged well, and once they are followed up, they recover within 3 months, that sort of thing. We have had a few patients where we repeated the CTPA and the PE is sort of gone, and so they respond well. So that's all I have to say. When you face a PE patient, re-stratify them and don't be worried to give lytic therapy. If you are having some difficulty making decision, you share the decision making and make it like a multidisciplinary, consult people. That's all. Okay, anyone else with any other questions?
Hi, again. With regards to the choice of the fibrinolytic agent, basically for reperfusion, in the last 2 months, the patients in Queen 2, we had not 1, not 2, but 4 patients that we reperfused. 3 of them were massive PEs. 1 of them was submassive. I believe that particular case was discussed by Jason Lowe with you as well, I believe. And I think for us over here, it was a 50-50 mix between alteplase and streptokinase. We had in fact used all 3 regimes. We had used the accelerated regime for my case. My other colleague gave 100 mg over 2 hours, and the other 2 cases were given the streptokinase full dose. With regards to alteplase, because alteplase is a neuro-only item, so we had to speak to our neurology colleagues to proceed with the alteplase itself. I believe, I think in consideration to why I think some of the alteplase were given was, I think because if we had the alteplase, we would prefer to give alteplase as opposed to strepto, mainly because of the bleeding risk is deemed less. Deemed less compared to streptokinase. Of course, cost is definitively an issue.
Yes, cost is definitely an issue. And just, Dr. Ng, just a small note on that. I think you have also followed the acute cardiovascular symposium on pulmonary embolism, and they said that in patients with this high risk hemodynamic instability, that means that one high risk, right? You giving the alteplase is not an issue, but it's actually in patients with the intermediate risk, the one where there is no hemodynamic instability, giving the lytic therapy, according to the Europeans, it's not really recommended. That is what the latest consensus is among the European guys. But here, because of our boss, Dr. Liu as well, his reasoning is like Ashley mentioned earlier, once you have a RV dysfunction, then we give a patient benefit of the doubt. So whatever decision we make, as long as we get the patients on our side and we inform them, you know what, any lytic therapy, yes, of course, some will have low risk, some will have higher bleeding risk, but there's always a bleeding risk. So if they say they understand the risk and they have given consent, then we just go ahead. We will lytic, and I like the fact that you're using more alteplase. I personally am not, I've not really used it so far, but I think that you guys have more experience. What about Queen 1? Are you guys also using more alteplase compared to streptokinase? Anyone has experience from Queen 1? No?
I think Queen 1. I think
No?
I didn't know that Queen 2 has all the cases that we thrombolized from Queen 2 lah.
Oh, okay. No, because we do quite encounter a few of them where they consult us for thrombolysis from Tawau, from all the specialist hospitals. So I remember Sandakan, Tawau, they have quite a number of PE patients. So I mean, we just litic and most of the time it's streptokinase. We can't go for altiplase in so many patients. So I guess I'm surprised that Queen 1 has not that many patients. I thought those were the medical, all the top medical guys are there. So I do share your experience more of altiplase if you guys are using it. But I would caution in terms of bleeding with altiplase. Let me know how it goes. So if anyone else has any questions, I have to congratulate both Yong and Ashwin. Very well done. Very well put, saving us time and giving us the most important information. And I think that this slide, it will be very helpful in diagnosing and as well as classifying the patients. So once you know where you are, the treatment becomes easier, or it's never not easier, but you have a flow of thought, and always discuss it with people before, don't take it on yourself. That's all.
Thank you so much, Dr. Seswa.
Thank you, Dr.
Hi,
Suha.
Okay, all right.
Hi, Dr. Suha. There's just one last question, I think, in the chat box.
Chat box, okay.
Yeah. So Dr. Phoebe is asking, in reassessing PE after completion of 3 months of OAC, and then when we're talking about reassessing the risk factors and symptoms to guide if we want to prolong it, is there any need of repeating the imaging modality?
Most of the time we don't. I don't think so. I think once you've completed the period of 3 months, but I do caution the Ashwin, there is another slide that you have. Yeah, so if according to guidelines, in most of the time, once we have anticoagulated them, then we don't really repeat the CTPA unless there is a suspicion. Some patients, from my experience, like you say, all these cancer patients, if they are higher risk, then we want to prolong the treatment for at least 6 months. But if it's a basic low risk kind of thing, then most of the times we are giving for 3 months only. Then we stop the anticoagulation and we follow up clinically, because it's always based on resources and also cost. So we try, most of the time it's about 3 months of anticoagulation.
Okay. Thanks, Dr. Suha. And Dr. Gordon made a comment just in response to Dr. Justin's question. Said, shedding light on some autogeriatric cases, that PE is very common in hip fracture in elderly during the perioperative period. And in general, it is not a contraindication to proceed with OP as long as GA can handle the ventilation part.
Yeah, so I guess that is like a multidisciplinary thing, right? They will decide, the GA will decide, the surgeons will decide. I think once patient is anticoagulated, then there's no other reason. I think there'll be it should be going by patient to decide when they want to go in for the OP.